Hello, and welcome to our HLA and organ matching session for the Transplant Families 2022 conference. We have the benefit of a couple of extremely knowledgeable speakers on those subjects, some who have done some original research. And so with that said, I'll go ahead and dive right in. We'll start with Catherine. Is it Theis or Theis? I'm sorry. Okay, and she has 12 years of experience working with children and families with heart defects. She completed her education in her hometown of Chicago, Illinois, and got her BS with a major in nursing from the North Park University here in Chicago, and I'm in Chicago, so. And in 2010, and she began working at the PICU, the Pediatric Intensive Care Unit, and then the cardiac care unit at what was then Children's Memorial Hospital, which later became Anna Robert H. Lurie Children's Hospital of Chicago. She continued her studies and received her doctorate of nursing practice in pediatric acute care in 2018 from Rush University, also here in Chicago. And she's now a heart failure and heart transplant advanced practice registered nurse in the cardiac care unit at Lurie Children's Hospital, and has a passion in family education. Outside of work, outside of her day job, she enjoys biking, art, and travel. So with that said, we will let Catherine take it over.
Thanks so much for the wonderful introduction. All right, perfect. So I have the pleasure of speaking with you today about the transplant evaluation process. As Joseph was just saying, I have a background in heart failure and heart transplant. So I will try to include information with other organs, but it's not quite my background. As we get started, these are the objectives of the talk. We'll provide a general overview of the transplant evaluation process. I'd like to highlight the multidisciplinary approach to organ transplant, review special considerations for listing, and discuss some basics of organ acceptance. And then this is just kind of the overview of what we will talk about as well. So, as you know, the need for transplant evaluation starts with native organ failure. So regardless of which organ it is, you have an organ system that cannot meet the body's needs for proper growth or function. And I just kind of highlighted the solid organ transplants here, but some of this talk also may apply to the other types of transplants as well. In terms of diagnosis, you begin with a history and exam of the patient, what's been going on in the background. Is the patient's functional capacity changed? Are you able to walk upstairs? Are you able to eat, grow? How well are you able to really function in daily life and do normal things, keep up with your peers, that kind of thing. Again, feeding and growth is a big marker, especially in heart failure and heart transplant. Sometimes those are the first signs that things aren't quite right, is where we kind of stop growing and we kind of hit a plateau there. There's different laboratory tests that we perform. Some of them are more specific to different organ transplants, but we'll make sure to kind of follow up on different tests like that. And then there's, of course, specialized testing, which would be more of the imaging modalities, X-ray, MRI, CT, echoes, EKGs, pulmonary function tests, those kind of things. So we have organ failure, now what? So then we begin the transplant evaluation process. I like to highlight the importance of the timing of this. Ideally, we want to go into the transplant evaluation as healthy as possible, but obviously knowing that transplants are a limited resource. So it's not that, we decide, hey, we don't really want to do the next surgery, we want to get a transplant instead. It doesn't really work like that, obviously. So we want to kind of reach a point where it's looking like there's no further surgical options that really have a good long-term likely outcome. And then it's really time to start thinking about transplant. The other thing about timing is that the transplant evaluation is a very long process that involves meeting with so many different subspecialties, lots of different tests. So ideally, if we have the luxury of time, we'd like to do that over the course of multiple days, which often is possible on the inpatient side of things. Obviously, on the outpatient side of things, depending on how far you live from the hospital, it might not be ideal. And then also depending on how sick the patient is coming into the transplant evaluation, if there was a sudden event that kind of led to this, sometimes we have to kind of just really get going and start things up really quickly. But obviously that can be pretty overwhelming for a family and a patient as well. I did want to highlight during the transplant evaluation, we like to emphasize that transplant is a choice. So transplant is not perfect. It's not a cure. Obviously, we have come so far in terms of research and success rates. Different medications have only gotten better and better, but it's not a cure by any means. Really, we're trading one set of issues with the failing organ for another set of potential issues involving lifelong medications, frequent lab draws, other comorbidities that may occur. So other things that like other risks and things that can occur throughout the transplant process. And then all organs also have a lifespan. So organs don't last forever, and they are getting better and better in terms of lifespan with new medications and new technologies, new ways to monitor the life of the organ or the health of it. But it's still not perfect. And the lifespan really depends on the age of the transplant recipient, the type of organ, lots of different factors involved along that those lines, as well as the medications, obviously, you're using. Our goal in any transplant is really to extend your lifespan and to reach a point where we're improving your quality of life and really able to enjoy kind of normal things again. I'd like to highlight the multidisciplinary approach. So as I said, it can be very overwhelming for families to undergo the transplant evaluation because you're meeting with a whole slew of people in the course of either one day or multiple days, but it can still be very overwhelming. Some of the disciplines, well, most of these are all required. So we have families meet with social work, med psych, the dental team, palliative care, nutrition, child life, and pharmacy. And then, in addition to that, we also have them meet with like the nursing staff, financial coordinators, transplant physicians, transplant surgeons, and then the transplant and ICU, like nurse practitioner team or physician assistant team, really the medical team, as well as organ procurement coordinators. A few ones to highlight quickly include like financial coordinators really help with helping to plan for transplant finances, which I know there was a separate talk on that, which will be very valuable. But transplants are very, very expensive from start to finish. So really planning for that and ways to kind of work through that. Transplant physicians and surgeons, as well as the ICU and nurse practitioner team, really kind of go over the risks and benefits of transplant, the outcomes of that institution, as well as different risk factors later on after transplant as well. And organ procurement coordinators are also very unique. They are the ones kind of behind the scene, putting the patient actually on the country's list, and they kind of keep all the paperwork up to date in the background and make sure that when an offer does come in, they're kind of the first ones to feel that offer, and they relay it to the medical team, the surgeons, and kind of are helpful in trying to coordinate that organ if that is the accepted organ. And they are the ones that actually travel to the donor hospital. In our hospital, our surgeons also go to retrieve the organ. That is not always the case, but they go on the actual procurement trip and go to the donor hospital and bring it back. And then other ones that I really wanted to highlight, because I just cannot stress how important these are enough, are social work and psychology. These kind of work together. We often have them meet with the family beforehand as a group, and they really help to delve into like what kind of support system the family has. How are your coping strategies? What kind of stresses or needs can we help you with? What are your concrete resources, and how can we help to mitigate any other like lack of those or any stressors that we can improve for the family or help them improve? And then what kind of ongoing support do you have? Because transplant is just such a different lifestyle that you always need more support. And then psychology is especially important for our teenage patients or preteen, young child, any child really that goes through their teenage years with a transplant. Those are just such pivotal years that, you would just hate for them to decide that they want to stop taking their medications or just are really having difficulty coping with their situation. The other really important one is pharmacy. They go over with the family all of the medications before, so pre and post transplant, they meet with the family and they kind of do a thorough education with the medications. All the medications or several of the medications will be lifelong to keep the transplant healthy. They delve into, is the family able to measure the medications, especially important with liquid formulations or injections. How good are they at maintaining the medication schedules? Any objections to giving medications? Are they able to give them reliably on time? And it's very simple, but are they able to read medication labels? Interestingly enough, sometimes there are families that either can't read or can't read in English or in English characters. We've had a few families come from overseas that we've had those cases, in which case we have had some workarounds where we have used medication like stickers and like animal like labels, things like that, to try and help them identify this medication over another one. And then the transplant nursing and APN and medical team or nurse practitioner team really go over, as we mentioned already, the listing process, the waiting process, organ acceptance, pre and post transplant care, some goals and risks, and they also do the consent with the family as well. Some specialty consults that are involved in the transplant process. So it really depends on which organ system we are needing to get transplanted, but often there may be other organ systems involved. If you have a history of heart failure, for example, have you had a congenital heart defect for all of your life and now you need a heart transplant? So how, often with heart failure, you have the need for lots of medications that can be really toxic to your kidneys. So how is your kidney health at that point that you're needing a transplant? Because all of those things are so vitally important to the success and health of the patient before and after transplant. And then immunology is a consult that at our institution we're using more and more before transplant as well as after. Immunology is helpful in identifying if there are any baseline immunodeficiencies that we may not already know about. Often those things can be missed. Obviously kids kind of get sick frequently, but if there is a background immunodeficiency that can really influence, maybe they might need prophylactic antibiotics before transplant, they might need different antibiotics after. It also influences what our initial medication plan for the initial anti-rejection medications are. So it really can be very influential for planning for the transplant as well. And then of course, with transplants, we have to test all of the things. So we do a lot of lab testing before transplant as well as along the way, and of course after transplant. Most of the pre-transplant labs are related to like infectious labs, any vaccine labs. Some are organ system specific. We of course check blood types multiple times to make sure that we're extra sure that this is going to be the right blood type for the patient for the transplanted organ as well. Isohemagglutinin reactivity, that one is specific for children that are under the age of 2. We potentially would send this lab to find out how reactive they are to other blood types, in which case they might be eligible to receive a transplanted organ that is a different blood type than their own. And that's really related to their immature immune system. And I believe our next talk will touch on that as well. And then HLA and PRAs, which we'll go over more in our next talk as well. So those are really, in a nutshell, the background antibodies of the patient, as well as the PRA is how reactive they would be to a potential population sample. So that helps us to decipher how successful we think they will be at accepting like a new organ, or are they likely to have rejection early on, those kind of things. I also wanted to highlight our infectious labs are super important because obviously we can't transplant someone that has an active infection. We're about to drive down their immune system very quickly. So we want to make sure there's nothing concerning going on. And then as far as vaccines, we really like to accelerate the vaccine schedule if we can. And if there's any vaccines that they received already that they weren't immune to, why were they not immune to that? Do we need to just re-immunize them, or is that another discussion that we should have with like the immunology team? Are they not reacting appropriately to these different vaccines? And then testing and imaging, again, is organ system specific, but we do CTs, MRIs, ultrasounds, echoes, EKGs, stress tests, pulmonary function tests potentially. And those all really help us figure out how well is this organ functioning? Is it getting worse, getting better? Are there different things we should be doing for this patient? What is the size of the organ? And so in the case of like hearts, probably different organs as well. Often in heart failure, your heart enlarges. So in that case, a small child that usually would not be able to accept a very large heart, in the case of heart failure, they have such a large cavity in that area. So they actually may be able to accept a heart of a much older and larger patient just because they have the space. And then blood vessel anatomy, what are the blood vessels looking like, you know, toward the kidney and that kind of thing. And what's their functional status? Are they, you know, we might do like stress tests, in which case we're trying to identify, is this patient safe to go home, or are they able to tolerate exercise? What are their symptoms throughout that process? All right, so after all of those consults, labs, and the whole slew, it can already be very overwhelming, but then we kind of take all that data and bring it over to our committee review. Most or all transplant centers would then gather as a group. They do a transplant multidisciplinary review, which is a group discussion of the history, the risks, and the contraindications to transplant. Really important to really look at the patient's like overall picture, what other organ systems are involved, what other things do we need to kind of plan for, or are there any things we can improve upon as we kind of wait for transplant. As far as contraindications to transplant, we typically say there's no absolute contraindications. It's really on a case-by-case basis, but that being said, you know, we can't really transplant someone in like active cancer, in like a state where they have multiple organs failing. Certain syndromes, certain metabolic disorders are less likely to be eligible for a transplant. It really depends on the situation. But I would say in general, is the disease process going to limit the patient's life to less than what the transplanted organ would, what the lifespan is for the transplanted organ? So really our duty is to really kind of balance those and make sure that we are able to optimize the life of the transplanted organ as well as our patient. As far as the transplant listing, so we then kind of discuss the listing plan. Are we going to list as like the highest status? So in the pediatric heart transplant criteria, at least in the US, our highest is 1A, and then 1B, and then 2. So really, what kind of medications and what kind of functional status the patient has, how symptomatic are they, how has their growth been, all of those things give them like different criteria. So really you're kind of checking things off a list. There are cases where we have basically petitioned the organ procurement networks saying that, you know, our patient doesn't technically qualify for this higher status, but we think they have these risk factors, and we're afraid that, you know, if we don't bump them up on the list, that they potentially could suffer consequences of that. So there are some exceptions, of course, built into it. And then with all listing statuses, there's also a status 7. It is in hearts, but it's basically a pause button for your listing. So if you're listed inpatient, you start accruing time as whatever status you are listed as. And then if you get an infection or you're a little bit too healthy, so kind of, you know, different reasons why we might pause you, we can change you to status 7, but basically that keeps you on the list, but then essentially just pauses your time. So then in, you know, a week or whatever time frame we decide to restart, we literally keep all of our time and we, you know, continue waiting for the transplanted organ. And then other listing considerations include HLA and PRAs. Really your PRAs, if you're very reactive potentially to other populations that you could potentially get an organ from, other people, would we consider, just kind of ignoring those antibodies? Would we consider desensitizing? So that involves giving dialysis, well, not dialysis, but we insert a dialysis catheter and perform plasmapheresis to remove antibodies from the patient. And then there are different medications that we use to continue to clear out those antibodies. So some institutions do desensitizations while others don't. Some institutions are willing to transplant someone that has pretty high antibodies while others aren't. So it's really institution dependent. And then are they a candidate for an ABO incompatible transplant, which we talked about? So that are they young enough, and is their reactivity to other blood types low enough that we could potentially safely transplant a different blood type into their with their transplanted organ? All right, and then waiting, it really just sort of depends on what our listing strategy is, how well the patient's doing, but you could potentially be waiting inpatient or outpatient, really depending on how things go. But while we're waiting, regardless of if you're inpatient or outpatient, we want to really optimize whatever we can. So we want to optimize growth, nutrition. We want to give vaccines often on an accelerated schedule to try and make sure the patient is as protected as possible going into the transplant, because we know we're going to immunosuppress them heavily later. How is their support? How is their function? We like to really ramp up rehab, physical therapy, OT, speech. All of those different services are really helpful in making sure these patients are able to be as functional as possible, even with their organ failure. And then psychology support often is just so very important. Education, both for the families and for the patient, depending on the age. We can already start teaching them about post-transplant things or pre-transplant things, really. We kind of will continue to teach them along the way. And then in the case of children waiting in the hospital for a very long time for their transplant, really we even make sure that they have school services continuing, and we like to try and minimize how much time is lost basically while waiting in the hospital. And then other considerations include directed donor transplants. Those are obviously not possible in heart, but in kidneys and livers and different organ systems, you might be able to do those. Directed donor blood. So in our heart transplant population, we sometimes will chat with our families about potentially donating blood so that there's one donor giving the same blood to the patient each time that they need it. And that way we can control the antibodies that they're exposed to. In discussions with my colleagues, I've learned that that actually can be controversial depending on what organ you are transplanting. For instance, if you get a heart transplant and you've had directed donor blood from your parents, then potentially if you need a kidney transplant or something else later, then you might already be sensitized to your parents' antibodies and not be eligible for their kidney. So it really depends on the institution and the situation. And then we continue to watch our PRAs, potential desensitization if they need. And then we like to optimize our medical regimen and support. Do they need titrations of their medications? Are we adjusting things to make sure that they're less symptomatic if possible? And then do they need any other support devices? So in the heart world, we could potentially do ventricular assist devices if they are worsening and need more support. Kidneys obviously might need dialysis. Do they need specialty pulmonary support as well? And then as we're waiting, it looks like one of these slides are not really, the color didn't really show up well. But really, we're constantly reevaluating the patient for, are they worsening? Are they getting better? We periodically will bring them into clinic and just kind of check on them, or in the hospital, we're just constantly reevaluating labs and reevaluating changes to the patient. But potentially you could get worse and need more support, or get better and potentially be inactivated and maybe not need an organ transplant at this time. And then if you are waiting on the list for a longer period of time, then we do at minimum yearly reevaluations where you kind of talk through all of those different people again. It's usually more abbreviated than the initial evaluation, but it is important to kind of discuss everything. And then for organ offers, there's no single list. Each donor has a unique match list. That is based on geography, the different kind of regional and national zones of where you live, the blood type of the donor and the recipient, their age, height, and weight to make sure that the organ will actually fit. Listing status, obviously, if you're on the higher listing statuses, you would get priority over the lower ones. There are some exceptions to that rule. For instance, if you are listed for a heart-lung combined transplant, if you are given an offer for a lung, then the heart automatically goes with the lungs, regardless of where you are on the heart transplant waiting list. So there are some advantages in some cases. Waiting time is really organ specific and status specific, but can be days, weeks, months, potentially years. So it really is very, very, very dependent on many factors. And then antibodies. Are we restricting any antibodies that we think would be too risky to transplant, or are we willing to kind of accept those? So really kind of depending on those scenarios. And then the offers would be reviewed by the transplant team and the surgery team. Generally, we like to try and kind of, if offers are coming in, we don't really tell the family unless we're like positive that this is the one for them. It's just too hard to kind of go back and forth with those offers. And in conclusion, so transplant is really an individual and family choice that ideally can improve quality of life for the patient and family. Transplant's not a cure, but really more of a trade. There are some risks involved in it, and you are trading some problems for a different set of problems. There's many considerations that go into the timing of and initiation of the transplant evaluation, and it's vital that each patient undergoes a thorough multidisciplinary evaluation. Our goal with all transplants is to optimize the patient's life and functionality while waiting. And really, the healthier you go into a transplant, the better outcome you'll have after. So we really want to try and optimize as much as we can going into the transplant. Thank you so much.
Thank you, Catherine, for that information. If you have any questions, please put them in chat, and we'll, if we have time, we'll post them at the end, or field those questions at the end. If not, we'll try to address them offline. I was remiss in not introducing myself at the beginning of the session. I'm Joseph Hillenberg, a heart transplant dad. My son is 10 years post. He was transplanted at Lurie, or what became Lurie, in 2012, and he's now 10 years old. He was, as Dr. Halpin will go into here in a moment, she'll talk about ABO incompatible heart transplantation. My son was ABO incompatible, and so we owe a lot to her center, as I'll get to in a moment. Dr. Halpin is a PhD candidate at the West Research Group's Cardiac Transplantation Lab in the Department of Pediatrics, Surgery, and Immunology at the University of Alberta. She has worked for several years in the human leukocyte antigen, or HLA field, and is also an assistant clinical professor in the Department of Laboratory Medicine and Pathology. I think that her biography that she gave doesn't do her credit. She has performed a lot of original research here. Not only that, but she works for an all-star team at her center. If you're listening and your child has received a heart transplant, I promise you that her team's added years onto their life. So I just want to make it clear that we all owe her team a huge debt of gratitude. So with that said, we will let Dr. Halpin take it away.
Thanks. I hope I can live up to that introduction. I'm not quite doctor yet. My PhD defense is at the end of June, but I like the sound of that a lot. So I look forward to that being part of my name. And as Joseph said, my PhD supervisor is Dr. Lurie West, who is, I guess, the pioneer and of ABO incompatible pediatric heart transplant. And she's an incredible clinician researcher and an amazing PhD supervisor. So I'm very, very fortunate to work with her group. And the HLA team that I work with also is just incredible. The University of Alberta is this little small Edmonton-based place with lots of fun transplant activity. So I'm very lucky to work on these teams. And, this is primarily going to be a talk about HLA, but I am going to talk about ABO a little bit at the end, because I think we have a lot of room to learn in that space. So let's just jump in. I'm going to try to demystify HLA for you a little bit over the next 20 minutes or so. So HLA stands for human leukocyte antigen, and I'm sure you've heard the term HLA. We talk about these being on leukocytes, which is our white blood cells, but they're actually decorate our whole body. They're on every cell we have, which is why they matter in transplant, because they're also on our organs, these HLA proteins or markers. So I'm going to briefly describe HLA typing, HLA antibody assessment, and that PRA value that Catherine mentioned, and then a little bit about the cross match. And I'll finish with a little ABO introduction as well. Oops, sorry. There we go. So why do we have HLA? So we actually don't have HLA because of transplant. HLA markers or proteins or antigens, I'll use those terms. I'll try to be clear when I use them. Try not to be so acronym focused here. But essentially, these markers are like our barcode of our immune system. They tell our immune system, this is me or this is not me. And transplantation, our immune systems didn't evolve for transplantation. They evolved to fight infections. And so transplant is a surprise to our immune system. We've actually learned a lot about our immune system because of transplantation. And so HLA is just kind of an interference pesky thing in transplant, but we still need HLA or we can't fight infections. And this slide is busy, but I really just want to show you that HLA markers or proteins, they're all encoded for on genes that are on chromosome 6. So we all have HLA. And those red markers on there are the genes that we match in transplant or look at in transplant, but that's still evolving. And when I first started in HLA in the early 90s, we didn't actually look at all the markers we look at now. So this is a continuously evolving field where we're learning all the time. And so this is kind of roughly what HLA antigens look like. So do you see my pointer when I move it on the slide? I'm not sure. But anyway, so on the left, it says class 1 HLA. On the right is class 2 HLA. Don't worry so much about that. They have slightly different structure. They're likely equally important in transplant. In HLA, we like to fight about that as to which matters more. But ultimately, they're both considered, and we look at both of them when we're matching for transplant and looking at antibodies in transplant. So the typing itself is a pretty straightforward process. It's probably one of the more simple things we do in the HLA lab. And essentially, we do the typing because we want to know how well matched or what is the degree of compatibility between a donor and a recipient. And then doing the typing on the patient also helps us to understand and interpret HLA antibodies that we might see. And so essentially your local HLA lab, who are behind the scenes, who you never probably get to see, are isolating DNA from blood samples. And then we do a PCR amplification of your DNA, looking for specific sequences that give us this information to say, this is the HLA typing that you have. And so just to give you a sense of the alphabet soup that is HLA, this is actually my HLA typing because I'm a scientist and not creative. So it's just easier for me to put up something that I know. So these are my HLA antigens. And the takeaway from this slide is there's lots of different HLA antigens. There is a lot of possible combinations of these HLA antigens. So it's really rare for you to be completely HLA compatible to an unrelated person. So in bone marrow transplantation, we have registries for that reason, where we're looking for close matches. If you have a sibling, you have a 1 in 4 or 25% chance of being the same HLA as them. And parents are half matched to their children because we share our HLA from mom and dad to children, just like we share all of our other genes. So takeaway from this slide, there's a lot of potential HLA antigens, and it's the word we use is polymorphic, but what that means is there's a lot of possible typings. And that's good for our immune system, complicated for transplant. So the antibody testing, I think, is probably the part that you think about the most as a transplant family, or that you discuss the most, especially if you are a patient and you have antibodies or your child has antibodies. So why do we have antibodies to HLA? Well, basically, unlike ABO, where we naturally make ABO antibodies eventually as we get older, HLA antibodies are only there when we've been exposed to HLA that isn't ours. And that happens through really specific things. So blood transfusion, which can also happen at the time of a VAD or Berlin heart insertion, so that can be an issue. Exposure to donated tissues. So for a pediatric heart patient, that might be a homograft if you had hypoplastic left heart syndrome, or a pulmonary valve if you had to have some of that kind of repair. Previous transplant is also a way that you get exposed to non-self or HLA from other people. And pregnancy is probably not such a pediatric sort of focused thing, but in our adult patient population, this is a big issue. And women are actually very disadvantaged in transplant because of pregnancy, because we make HLA antibodies in pregnancy. So why do we measure these antibodies? Well, we need to know, and Catherine touched on this too, how many antibodies are there to get a sense of how hard it's going to be to find a compatible donor. And we do antibody testing at the time of workup and continuously while someone's waiting. And it's especially important if an event like a transfusion happens that we repeat the antibody testing after that. And so, let me just advance here. So I'm not going to get too much into the technical, although this is like my favorite things are always the technical things to talk about. But so we do use something called this Luminex methodology, which is a type of something called a flow cytometer. And that's how we measure HLA antibodies in the HLA lab now. This wasn't the case in the past. We used cells and a bunch of other different methods. And this ability to use this method I'm about to describe to you has really revolutionized the information we can provide to the clinical team and therefore to you as families. And so essentially we have these tiny little polystyrene plastic beads, and they're coated with individual HLA. And that's really important because, as I told you before, there's all kinds of HLA alphabet soup antigens that you might make antibodies to. So we need to know that. And so these individual little beads that are manufactured for us by commercial companies who are just excellent partners to lab. And then we mix the patient blood with that and we see if antibody attached to those beads. So what that looks like in a picture is we would have, I'm from Canada, so I use little maple leaves to represent the HLA antigen here. But let's say this bead is specifically only has an antigen called DQ7 on it. And the name of the antigen doesn't really matter. And then we would add the patient blood, the liquid part of the blood, the serum or plasma. And if antibody was present, it would attach to the bead. And then we add an antibody that tells us, oh, there's an antibody there. And the second antibody is labeled with a fluorescent marker. And then we can acquire that, like we run it through our instrument and it says, oh, DQ7 bead lit up. And so we know there's DQ7 antibody. And that's essentially what we do. But we do that multiplied by several hundred beads to get a full antibody profile. So here's just an example of like 2 beads that might be present. But really, these beads are pooled together. So in one individual well, we would be adding blood and we would be testing for antibody to hundreds of things. So just to give you an idea of what we would see in the lab, and the clinicians probably don't normally see this specific result, but this is tiny, so don't worry that you can't see it. But this is how much fluorescence is present. These are individual beads. And so in this example of a patient antibody, there's the patient had antibodies that react to all these individual beads. So like the second one is B7, for example. So then we can provide a report to the clinician that says, these are all the antibodies. And then they can take that into consideration for donors that might have those antigens. And as Catherine said, it's a little bit, and I'll talk about it in a minute too, it's not a cut and dry thing. These discussions get complicated as to which antibodies we are worried about or not, what would we be willing to cross. This is just another example of this, but this is class 2 antigen panel. So you get the sense that we get this fluorescence output, and then we can report to the clinician, these are the antibodies that are there. And so PRA is a term that we use a lot, and Catherine mentioned this too, but I just wanted to define it a little in case you've always thought, like, what is this PRA term? So it's an old-fashioned sort of acronym. We love acronyms in science and the lab and in medicine in general, so I apologize for that. And so PRA is panel reactive antibody. Basically, it means how broadly do you react with the population? So if you have a 0% PRA, that means basically you have no antibodies to HLA. If you have a 70% PRA, that means your level of antibody, the number of antibodies you have, means you would react with about 70% of the population. CPRA is just a modern way to define PRA. So CPRA and PRA are interchangeable terms. The C just means calculated from the single antigen bead. So if you're sensitized, and Catherine used that term too, it means you have antibodies. So we just broadly say, oh, you're sensitized. It's like this like a broad word to describe that you have reactivity to HLA. And so if you're unsensitized, that's lucky, then it's easier to match you. If you're sensitized, then, how sensitized are you? Is your PRA higher or lower? What would we be willing to cross? Do we want to try to do things while you're waiting to try to reduce your antibody level to desensitize you, as Catherine said? So just to describe what the PRA is, so this exact same serum that I showed you before, and this is how I calculated this. This is the Canadian CPRA calculator, but there's one also for UNOS that you can just Google UNOS PRA calculator and you will see it. This person actually has an 80% PRA because the antibodies that they have are to common antigens. And then the class 2 was similar. So it has, oops, I think I skipped 2 slides there. This is, sorry, that's the class 2. It's, 68%. And then if you combine those two things, then it actually becomes higher. It's 96%. And as Catherine said, you may have what antibodies you call or the antibodies you report. This is where you get into some heavy conversations between the HLA lab and the clinical team. So for example, these antibodies that I put in the box here are to DQ targets, DQ789. That's not really that important, but they're lower reactive on our panel. So some programs might say, you know what, I'm willing to cross that and I'm going to give more immunosuppression at the time of transplant. Other programs might say, I don't know. And it's a lot of factors that go into that. And this is a very constant communication between the HLA lab and your clinical team to try to make those decisions together. And I'm super briefly going to talk about epitopes. So this is a term, I only bring it up because I know this is an extremely engaged patient population, and you guys are smarter than me in so many ways. So you might have heard this and you might think, wait, what is an epitope? Why would we talk about epitopes? What does that mean compared to an HLA typing or an HLA antigen or individual marker? And essentially, these are like shared things between HLA antigens. And the way I like to describe epitopes is I say, I have 2 sisters. I'm the oldest, and like they like to remind me. And so, the 3 of us, we don't look like, if you saw us walking down the street, you wouldn't say, holy cow, you guys must be sisters. You look the same. Some families, siblings just have this like they're, you can just tell you guys are siblings. My sisters and I don't have that. Like if we were walking down the street together, you would never just immediately say, oh, wow, you guys must be related. But if you look closely at us, you can see that we have things about us that are the same. All 3 of us have the exact same color of eyes. 2 of us have the same nose. 2 of us have the same hair color, etc. Those are kind of like our HLA shared epitopes. They're things that we have that are the same about us, but you would never look at us and say, oh, you look the same. So just like HLA antigens, there's some HLA antigens that have the same nose, but you would never confuse them for each other. But they have this little piece of them that looks similar to the other. And there's biological reasons for that. But in transplant, this gives us there's some pros and cons to this. So we can use this idea of this shared epitope, and I give you an example here. So there's an HLA antigen called A2. So if I'm exposed to A2, I may make an antibody to HLA A2. That makes sense because I don't have it. I'm seeing it. It's foreign to my immune system, and I'll make that antibody. But I also might make antibody to all the other antigens that have the same nose or the same hair color as that HLA A2. So I might make a lot of antibodies that are actually not directly from that exposure, but things that have this shared epitope between them. So that's kind of the faux side or the con side of shared epitopes. But on the friend or con side is that also then we can actually match according to these epitopes, and it can actually be a beneficial thing. So even if you say, oh, I'm mismatched at 5 antigens between this donor and recipient pair, the matching might be actually better than it initially looks because of shared epitopes or just commonality between those mismatched antigens that isn't immediately evident. So I won't talk more about that unless there's specific questions, but epitope matching is something that we're really looking at in a lot more depth right now in our field of HLA. And I think that this may be something that's especially relevant to pediatric heart transplant where, matching is a luxury because there isn't a plethora of donors. You don't have living donors. And so this is a really helpful thing to understand if you're trying to personalize immunosuppression to the level of matching. And so do you have to match? Well, and the term match is like, really I prefer the term compatibility, because if you are matched or not matched, you may still be very compatible. If you do not have preformed antibody to your donor, you are essentially a match. And so, but if you do have some antibodies, low level or previous antibodies that are now gone because of things like pheresis that Catherine described, I sort of like to think of it as a spectrum of risk for immunologic risk for rejection. So the compatibility is helpful to know for a number of reasons. And there's just a lot of factors that we take into consideration, but you do not have to be a full match between donor and recipient for solid organ transplant, but we want to know, are there preformed antibodies to your donor? And if so, what are we going to do about that? And the cross match is a test that you also probably, if you're transplanted already, you maybe already have heard this term, or if you're waiting for transplant, you know that you will have a cross match at some point. And this is a physical test where we take the actual cells from the donor, usually from blood, but also could be from something like the donor's spleen or lymph nodes. We take those white blood cells from the donor and we mix them with the liquid portion of blood from the patient. And ultimately, this test is to say, is there antibody in the blood of the patient that's going to react with the cells of the donor? And we can't use the actual heart or kidney to do this. So we use the white blood cells from the donor as like a surrogate for that. And HLA labs are hoarders of samples. We have rooms of -80 freezers. So we'll actually go back historically quite often for the cross match and say, okay, 2 years ago, this patient had more antibodies. So we're going to also pull that serum and we're going to include it. And then we can give the clinical team a full picture of, current and past reactivity to this donor. And then they can make the best decision about whether or not that's the right donor for that patient. This is more relevant to any clinicians or transplant coordinators that are listening, but the HLA lab really needs to know if the patients had IVIG or any other immunosuppressive things that involve sort of biologic antibodies or other things, because these can give us all some non-specific reactivity in the cross-match. So sometimes your cross-match might not be, we might rely on more of what we call a virtual cross-match, where we take the antibody information and the typing from the donor, because any of these drugs make it, in some cases, impossible to do a cross-match. So we have backup ways of doing a cross-match if we need to. So in summary for HLA, we have the typing, which is, at the time of transplant, we would have the, a transplant workup, and then the donor is typed when it becomes available. So if it's a living donor, that might be earlier in the process. If it's not a living donor, then obviously it's when that donor is available. We have the antibody testing. This is done only on the patient side, not the donor side, and it's done at the time of transplant workup, while they're waiting for transplant. And many programs will actually do post-transplant monitoring, trying to just to make sure that there aren't new antibodies emerging that are going to be reactive to the donor organ. And then the cross-match is done at the time of transplant assessment for the case of a deceased donor, but it may be done earlier and later in the case of a living donor. So then I'll just finish by really briefly touching on ABO very briefly, because it is, actually in kidney patients, we also do ABO incompatible transplants at times, but especially for pediatric heart patients, this is a really important way to increase the pool of potential donors for a patient population that has limited access to donors, which is a good and a bad thing. So, ABO antigens, this is actually, I'm calling them a histo blood group antigen, because ABO is, of course, on our red blood cells. I think we all know that from biology class, but it also decorates our whole body, and that's why it matters in transplant. And so these are actually sugars. They're not proteins, and they are the result of these enzymes that we have from our genes that create these enzymes that then go on to decorate our bodies with whatever our blood group is. So I'm blood group A, so, my kidney, my heart, my red blood cells all have blood group A on them. And unlike HLA, where we only make antibodies if we're exposed to something, we have we start to naturally make antibodies to ABO early in life, but we're not born making those antibodies. So I have this window of opportunity, which is what Dr. West, initially capitalized on, which I'm sure was a very terrifying initial clinical trial for her. But she had a vision and she was right. And so this has really changed how we transplant infants for ABO, from an ABO perspective, that we have this window where we're not making ABO antibodies, because our immune systems actually can't make antibodies to sugars in the beginning of our life, any sugars, not just ABO. And so ABO matters in transplant because it can cause rejection. And so we need to know if it's there. As Catherine said, we do titers to measure that. And so this this is not animated here, but basically when you're born, you would have low levels of antibodies to A or anti-A or anti-B ABO blood group. And in the case of an O patient who receives an A heart, they go on to make anti-B antibodies, ABO anti-B antibodies, but they actually don't make anti-A. It's one of the rare cases of true transplant tolerance that we see. It's really kind of amazing that it works this way. And so, you know, in the titer, the blood bank, we do these titer tests where we make dilutions of the patient's serum, we mix them with blood, and we look to see, are they agglutinating the blood? And then the last titer, so in this case, 1 in 16, where there is an agglutination, we say, okay, this titer is 1 in 16. So the higher the number, the higher your level of ABO antibodies. And this is a method that works really well for transfusion, but it's actually quite limited for transplant for a number of reasons that I could give a whole separate talk on. And then also it's important to know that there's a lot of variation in how we do ABO titers. This is a really tricky thing for us in transplantation that we would love to actually have better ways to do that. So as Joseph said, and I know we're running so close on time here, but one of the things that we're trying to do, and this is a super busy slide that, just to give you the idea that we can take that same Luminex concept and use that to measure ABO antibodies and get a lot more of a clean, clear result that's more reproducible from center to center. So I'll close there. On future directions, I think we can possibly expand the window of ABO incompatible transplant. Maybe we can use A2 subgroups. Again, this slide is more honestly just for food for thought, and I don't think we have time to talk about it. And I just want to thank you guys so much for allowing me to come here today. I don't get to meet patients very often. I think I'm getting more out of this than probably you're getting out of my talk. So I'm going to, just end there. And I think we have maybe just a couple minutes for questions.
Yes, so thank you. And for those who would like to know more about ABO incompatible transplantation, we are planning on doing a session probably in September as UNOS is looking to expand the criteria there in the United States to model what has been done in Canada on the basis of much of Anne's team's research. And so anyway, so look forward to that. We just have time for a couple questions. Maybe we'll keep it real brief. If I have Jill asks, if I have a heart on my license or have registered with Donate Life, and I think this is for Catherine, it means I'm giving consent for, does it mean I'm giving consent to become a living donor, or for example, to donate a kidney to someone else while I'm alive? I think that's the question. Jill, did you want to amplify that question? I think that I read what you meant.
That was your trivia question for the chat for the door prize.
Okay, I see. All right. So, okay. All right. I apologize. I will ask one other question. Are there any reasons why a parent would want to decline an ABO incompatible listing? Would it make things more difficult for them in the future? And this was actually a topic of some discussion in the Parent Heart Facebook group. So I think that goes to probably Anne.
Yeah, I mean, there's like UNOS is, for example, maybe wouldn't allow this, but in Canada, I'm going to give you an example, and hopefully this is something that could be more of a consideration in the US in the future. So in that example I showed you, an O patient received an A heart, and then they never make A antibodies, right? So we actually had this happen in our center. A patient was an O patient, he got an A heart, and he had, for a number of complicated reasons, he needed to be relisted. And so he was actually relisted for O and A, even though he was 4 years old, because he has no anti-A antibodies, because he never made them, because he had an ABO-A incompatible heart. So in a way, for the future retransplantation, if your registry allows, it's actually an advantage, because now you actually in the future could receive organs from more groups. Or even if you needed a kidney transplant in the future, that would be a consideration. So personally, from a scientific point of view, not necessarily a registry point of view, there are potential advantages. And Kat, I don't know, in your center, do you do more post-transplant monitoring for ABO antibodies in the case of ABO incompatible transplant? Is that
we do more frequent ABO or isohemagglutinin titers to monitor them initially, especially. And speaking of the research, I do recall there was a research study that we learned about recently. that showed that I think a center in, I want to say England, was transplanting patients with ABO incompatible hearts, I believe, and actually
you're right.
across
It's
higher titers.
Great Longman Street or Great Ormond Street, or
Yeah.
they have a street name in their hospital. Yes, they're collaborators of Lurie's. And actually, we transplanted a 6-year-old ABO incompatible heart not long ago. So we're writing up that case study also, because I think these are important to talk about. And they definitely do older children there. Mm-hmm.
Yeah, and they're able to, it sounded like they were able to cross higher antibody levels or higher reactivity. And had pretty good success rates. So it actually could be very helpful in expanding the donor pool.
The important thing about measuring ABO antibodies that we didn't really have time to talk about here, but it'd be a great future topic, is that when we use red cells to measure them, which is what we all do, you actually get false positives kind of that are relevant to the heart. So, they're saying they're crossing higher titers, but they're probably not antibodies that were actually relevant to the heart. So I think the hearts and ABO don't have the same kinds of ABO sugars on them. So these are like areas where I think we have a lot of opportunity to improve what we do. And this could be, expanding opportunities of age group, for example. Mm-hmm. Yeah.
So with that said, I think we're past time now. So we want to thank both of our eminently qualified presenters today for their time and for being willing to take time out of their day for further educate parents. Please, attendees, feel free to filter into the next sessions. We have a lot more planned for the day. We're all about halfway through. So thank you very much.
Thank you.